Hello and welcome to our segment from the doctor's desk. I'm here with the cataract surgeons, Dr. Chris Shelby and Dr. White Coleman. So glad you're with us today.
Thanks for having us.
Good to be here.
All right, we've been talking about cataracts and cataract surgery. So the question we're tackling in this segment, which lens choice is right for me?
So that's kind of a complicated question. You know, there's a lot of lenses out there, a lot of marketing's done around specific lenses. And we've gone over in previous segments, you know, the testing that's done when someone comes in the office. And the question is not necessarily which is the best lens. Some people say, well, I want the best lens. Well, that's not like the perfect way to approach it, because it's a question of what lens is right for you. There's a lot of options out there now. We have access to virtually all of them. And so based on the objective testing that happens when someone comes in the office and what their visual desires are, you know, whether they want to be glasses independent at all distances, whether they want to maximize distance vision, and what their objective testing says, that's how we make the choice for what lens is best for you.
All right. And so there is no, it sounds like, gold standard lens that's at the top of the heap. There's a variety of them?
There is. There's no catch-all, right? So it's not like you can just throw everybody into this one basket, you know, which is good, because not everybody is a candidate for every lens out there. And so, but, you know, you'll have patients, they want to be glasses independent, you know, as much as possible, but they have a history of RK, let's say, and it's, you know, 12 to 16 cut RK. That's a pretty difficult eye to do cataract surgery on, as in the regards of getting a good visual outcome. And so those patients aren't a candidate for a multifocal lens or some of the other premium lenses, but we do have options that give them the best possible solution to get out of glasses. You know, so it all depends on, like Dr. Coleman is saying, the pre-operative measurements and then their expectations and their wants.
You mentioned in one of our previous segments diabetes. Does diabetes, having that, does that affect lens choice?
Well, it can if you have diabetic retinopathy. So that's something we identify ahead of time, and we may alter our plan based on that. We may say you have some retinal abnormality, some swelling or whatever, and so we don't want to try a multifocal lens, because a multifocal lens should be used when you have a completely normal retina, everything else in the eye is totally healthy. Otherwise, we may want to just go for a distance target. And when we talk about a good visual outcome, we should separate those into two categories. One is a technically perfect outcome from cataract surgery. That means an uncomplicated cataract surgery. Nothing went wrong, everything went as expected, you don't have any unforeseen problems. That's going to occur no matter what lens we choose, 99.9% of the time. Modern cataract surgery is extremely safe. If we add up all possible complications that can occur during cataract surgery, they're much less than 1% of the total. So it's a really refined procedure. And then the second goal is glasses independence, a good refractive outcome, meaning not only did we get the cataract out of the way, but you also see very well without glasses. So with or without glasses, almost everybody's going to do really well, but our goal is to achieve that second level of success, which is glasses independence, and that's where lens selection comes into play.
All right, because I'll tell you, as we age, not having to worry about glasses is something I have had many older relatives who've ended up in nursing homes, and the glasses are the first thing that unfortunately they either forget, leave behind, break, they get misplaced. I mean, so to have that lens independence, like you were saying, is actually quite helpful.
Sure, it's 100% quality of life, right? You know, we only use our eyes all the time while we're awake, you know, and so being able to see as well as possible, whether that be with glasses or without them, is very important.
And you mentioned you know, the lens choice. Is there ever a point when you're in surgery when you realize that the lens choice you thought you were going to go with is not the right lens, and you have to maybe call an audible and figure out a better lens?
It can occur if there's unexpected things during the cataract surgery, if things are unstable. So we do some intraoperative measurements. Occasionally we'll say, based on this measurement, we want to change the lens power slightly so that we can give the person the outcome that they desired. But usually we know in advance. Probably 90–95% of our decisions are made before we go in the operating room, and that's the plan that we're executing. But occasionally you need to change based on the circumstances, especially if somebody's had trauma or something like that. We may have to put a lens in a different position, which requires a different lens design. And we can go through a little bit of that. We may bring up the first graphic just to show what an intraocular lens looks like. You know, I remember the first time I saw one of these was in an anatomy lab when I was in med school. And you know, when we take the cataract out, take the natural lens out and put the new lens implant in, it's a little tiny thing. You can't believe that this even works. This is an example of an intraocular lens, the image on the right. So, and the left one's an ICL, and we can talk about that another day. That's a LASIK alternative. But the one on the right is the one that is typically used for cataract surgery. And so that has a focusing power. When we go take your natural lens out, the capsule that surrounded that natural lens is still intact. That remains intact. We open up a hole in the front of it, we remove the cataract through it, and we put the new lens implant, the one on the right of the finger there. You can see it's a little tiny thing, and that replaces all the focusing power that came out of your eye. Occasionally people say, I don't want a lens with cataract surgery. Well, you know, if you were having cataract surgery in India and you were trying to do it for $3 instead of $4, you might have it without a lens, but you have to wear aphakic spectacles. Those are like Coke bottle thick glasses. And 50 years ago, that's what they did with cataract surgery. But a guy named Sir Harold Ridley in the Battle of Britain noticed that the aircraft canopies that were made of PMMA plexiglass, they would be shot with guns, and they would break in little shards, and they ended up into some of these pilots' eyes. And he noticed there was no immune reaction to it, and with that came the idea for an intraocular lens implant, which was actually the first prosthetic ever put in a human being. It's the basis for every other prosthetic that we have now, which is interesting. So before that, you took the cataract out, you replaced it with nothing. Occasionally you have to do that. That's very rare now, but normally it would be one of these implants of a specific design to achieve the result that we're trying to get to. But it's a pretty cool technology, really.
Yeah, because the eye and the body doesn't reject it, it sounds like.
Correct. It doesn't see it. It's an immune privileged site, and there's no immune reaction to that at all.
Fascinating. So we owe our ability to see post-surgery, post-cataract surgery, to those brave soldiers and airmen who flew in that war. All right, well, let's talk about this because, okay, so you've decided on which lens. What other factors are influencing those choices?
Well, going back to what we talked about earlier is the patient's desire to be out of glasses. How much astigmatism, that's one of the most important things on the surface of the eye, and we had showed it in an earlier segment with the topography, will tell us how much astigmatism is on the surface, and that's very important because, astigmatism, everybody's heard of it, nobody really knows what it is, but it's one of those things where, it's the bane of our existence because when you're nearsighted, you can see close. When you're farsighted, you can see distance. When you have astigmatism, you have doubling or shadowed imagery in all ranges. And so that's very important because most of the premium lenses that we use will correct astigmatism also.
And that wipes that out. That's not a factor anymore.
That is no longer a factor.
Does it change as you age with a particular lens, or is it pretty much a solution that lasts for someone's lifetime?
Basically the result you get from cataract surgery is relatively permanent. They did a great study where they followed people who had had cataract surgery for 30 years, and they said, what was their refractive outcome, meaning what was their prescription, their glasses prescription, if any, after cataract surgery, and they followed those people for 30 years, and basically they don't change much. So when you're young, your prescription's changing because your cornea is not stable yet. That's still changing. That's why we want to wait till people are like, usually 18 or older to do LASIK and have a fairly stable prescription. But once you get in your 20s or 30s, your cornea, because of cumulative UV light exposure, stops changing. That's why prescriptions get stable in someone's 20s or 30s. They don't change much anymore. But then you get in your 40s or 50s, it starts changing again. That's because of cataract progression. So once that cataract is removed, typically the refractive result you get, meaning if you achieve glasses independence, it's going to stay that way for the rest of your life. That's not to say that it can't drift a small amount, but for somebody who's extremely nearsighted or extremely farsighted, they're never going to be that extreme again. It may change a tiny bit where you need some glasses to drive at night, but basically the result you achieve is stable for a lifetime.
That's a huge achievement.
Yeah, for sure.
Yeah, and it sounds like the manufacturers are continuing to develop new lenses yearly. I mean, they continue to refine the process.
All the time, and it's kind of nice. It's nice to need cataract surgery nowadays in this day and age because the technology is just wonderful, and it keeps getting better. And what's interesting is we'll have some patients that'll come in. It's kind of like a computer. It's like, when should I buy a computer because in 6 months this one will be obsolete. And people are like, when do I need to have cataract surgery? And I'm like, well, you need to have cataract surgery when the symptoms are bad enough that your quality of life is affected, and with the original multifocal lenses that we put in, 15 or 20 years ago, we'll see those patients today and they're still working fine. And just because they're a little bit different now doesn't mean that we go in and we exchange them. It's a very stable procedure, and it's great. We have the best job ever, truly.
So we have some more graphics that we'd like to show our audience. Do you want to tell us
pull one of them up, we'll roll with it.
what we're seeing here?
So this is an example of the light adjustable lens. Like, this is the actual lens itself, and it's just showing a little diagram of the purple arrows or the UV light. So what you do with this lens, and this is specifically useful in people who've had previous refractive surgery, especially radial keratotomy, farsighted LASIK, to a lesser degree nearsighted LASIK, and sometimes we do some of those preoperative measurements, and they are conflicting. So you take one measurement, it says one thing, you take a different measurement, it says another. Those would be people that we have a lower confidence that with conventional lens technology, we're going to be able to hit a perfect target. That's when the light adjustable lens comes in. So it's pretty cool because you can put it in the eye and you don't have to perfectly predict what the focusing power of it should be. You just have to get close. And then you can come after the fact and check someone's prescription, see if they have residual farsightedness, nearsightedness, or astigmatism, and use a machine to apply a specific wavelength of UV light to that lens, and it actually changes the focusing power of the material after it's already in the eye. So that's great for people that we know are going to have variable results, because then we can still get up in that 98-99% probability of hitting the perfect desired target.
So rewind this for me. So you don't have to go in and do another surgery.
Correct.
To adjust that like you would with a lens of a camera. It sounds like the old-fashioned cameras where you would adjust the lens. It sounds like you're able to do this just with a UV machine, light machine.
It's been a game changer, especially for our post-RK patients, because it used to be we'd put a lens in an RK patient, then you had to let them heal for at least 3 months. And if they were a little bit nearsighted or farsighted or had astigmatism, the only way to treat that was either glasses, contact if you were lucky, or PRK, which is where we scrape the surface of the eye and then use a laser to correct any of that refractive error. Now, that works great, but it's a little bit cumbersome. And so now we take measurements, we put the lens in, we let them heal for several weeks, and then we start refracting them. It's better 1 or 2. And then when they say, oh, this is great, I like this, you simply dilate the eye and shine a UV light on there anywhere from 15 to 60 seconds, and it changes their prescription. It's really great technology.
Do they have to avoid, sunlight with UV rays in the future because of that?
That is a great question.
Yeah, that is a great
question. In the initial period, yes, you got to stay out of, or you've got to wear sunglasses to keep ambient sunlight and the UV rays from adjusting the power of the lens. Now, once it's adjusted and locked into its final position, you no longer have the need to do that. It will be stable where we left it.
Interesting. And then avoiding sunlight, UV light, is that something that all cataract lens recipients need to worry about?
No, just the light adjustable to prevent any changes. Most lens material is going to absorb a lot of the harmful UV radiation anyway. I mean, it's after cataract surgery, and those that have had it know what I'm saying, is suddenly things are brighter. So people are going to wear sunglasses, which is a good idea anyway.
Okay, so let's take a look at our next graphic. I believe we have one. Let's pop it up. What are we looking at here, doctors?
So, this is just a diagram of where the lens goes. Here you can see the cornea, you can see the retina, which we showed a photo of in the last segment. And so when we take the cataract out, this is where we put this new clear plastic lens. And this lens that we see in this graphic actually has some little rings in the center of it. It's some concentric rings. So this is the basic lens design, but this one is a multifocal lens. And the multifocal lens, the way it works is it has prism rings etched into it. And so that puts an image in focus onto the retina simultaneously from distance, intermediate, and near, so that you no longer have the need for glasses at any distance. I think we can take the graphic down now. But that is what most people desire in modern times, is maximum glasses independence. So if they're not like you and they haven't been in monovision for a long time, the multifocal lens, assuming all their measurements are normal, and we really want a normal eye for this. We want to have not a lot of dryness. We want to have good measurements on the astigmatism so that it can be corrected at the time of cataract surgery, and we want to have a totally normal retina. When all the stars line up for that, those are great candidates for the multifocal lenses. And they put you in focus at far, intermediate, and near at the same time, using those concentric rings that are etched into the lens material. And usually we do those in both eyes. Occasionally we'll do them in one if somebody has a problem with one eye, but they have a normal other eye, and you still get pretty good reading even when it's only in one eye.
For a lot of us, including myself, hearing something like that makes me feel like if I was experiencing vision like that, I'd be crossing the finish line at the Olympics. That would be so exciting.
Yeah, it is. It is. Matter of fact, full transparency, that's actually what I'm going to do with my left eye, is a multifocal lens, because we did the distance because I had a traumatic cataract when I was a kid, and so I opted just for distance. But I can tell you that near, as you know, it's not quite as good as we get older. But with this eye, I'm going to have him put a multifocal lens in, to give what's called modified monovision.
Sure.
So both eyes will see well at a distance. This one will see intermediate near, because it's already a little bit nearsighted anyway. And so I'm actually looking very forward to that.
Yeah, as some people out there probably have experienced themselves, what I hate is eating food and not being able to see exactly, how much is on my
Yeah, Dr.
fork.
Coleman's not quite there yet, but
I'm getting there quick.
It's sneaking up.
I'll be 46 this year. I got some readers around the house now. I guess that's reward for living this long. That's
As we get ready to wrap up, what else do you want to tell people about what influences the type of lenses?
Well, you want to throw one last graphic up right quick? We'll show one more lens design. This is an interesting one, and it's basically, this is called a small aperture or aphthera lens. So it's got a black ring, and you may notice that when you go to the eye doctor's office, sometimes they put little pinholes up for you to look through, and you can see a lot better. And that's a test to see if you have refractive error. That's a test to see that glasses or contacts are going to make your vision better, and that your retina and everything else is normal. So basically, they built that technology into a lens implant. So these would be for people who have corneal scars, or they've had previous radial keratotomy surgery, or they've had LASIK surgery, and they have a very unusual topography. On that battery of tests that we do pre-operatively, they have a lot of abnormality. And so previously, we didn't really have a good option for those people. Maybe you had to have cataract surgery and then wear a rigid, hard contact lens. But this is an option that what it does is it pinholes the light down through a very small spot, so abnormalities in the peripheral part of the cornea play less of a factor. So that's a rarely used lens, but it's great for this small subset of people that there's no other great options. So some people may fall in that category based on their preoperative testing.
It sounds like the scientists have been reverse engineering what they can do to help people's problems through lenses.
Absolutely.
Cataract
Matter of fact,
lenses.
the pinhole was actually a camera inlay initially. That's what they called it, the camera inlay. We'd create a LASIK flap and then put that little ring, that black ring on there. And it didn't work quite as well in everybody because it wasn't quite as biocompatible. And so they took it and stuck it in the lens, and it has been a game changer.
And the beauty of that is when you pinhole, when you look through a small aperture like a camera, as you reduce the aperture on a camera, you get a greater depth of field. So typically people with this lens can see good distance, and they can also read pretty good up close. Yeah. So it's another great option that we've got to handle a subset of people who otherwise there weren't a lot of things to do.
Which is exactly, it sounds like the goal in
Yes.
all of this. All right, in our final couple of seconds, we just want to mention how to reach out to you. The Cataract Surgeons is the name of the practice, and what's the best way to contact you?
You go to thecataractsurgeons.com, and it'll have all of our information and how to contact us there.
Well, Dr. Chris Shelby, Dr. White Coleman, we're so glad you're with us and telling us about choices of lenses and cataract surgery. We've learned a lot.
Thank you.
It's great to be here.
Thanks for being with us.